Greetings, everyone. Welcome back to Einstein's Eyes. John and I are ophthalmologists. My name is Carl Rosen. I'm an oculoplastic surgeon in Anchorage, Alaska. John Ditkoff is a cornea and anterior segment specialist. The reason we're called Einstein's Eyes is we trained at Albert Einstein College of Medicine at Montefiore Medical Center a number of years ago. And today's topic is
And I'm in New Jersey. I'm in New Jersey, what Carl's in Anchorage.
Right, John's in New Jersey, I'm in Anchorage, and yet we've merged the two ends of the United States. So today we're going to talk about blepharoplasty. It's an important topic. Lots of folks have blepharoplasty every year. It can be done by a plastic surgeon, an oculoplastic surgeon, an ENT specialist, even a dermatologist. And a blepharoplasty removes the excess skin between the eyebrow and the eyelashes. That excess skin that can cause hooding, it can affect your visual field, usually superiorly or laterally. It can reduce the light that gets in. And we determine it by visual field testing in the office. So if you have greater than 30 degrees, which is what you need, with and without tape, if that difference is 30 degrees, the insurance company usually agrees to cover the procedure. Generally, we do it at a surgery center. It typically takes 30 to 35 minutes while you're awake. Occasionally, we take fat from during the procedure. We can also do something called a browpexy through the incision, where you can elevate the lateral brow a bit. There are more procedures strictly for brow surgery. That'll be a separate video. But primarily a blepharoplasty is just skin removal. And again, maybe a small amount of fat. The sutures come out in the office in about 9 to 10 days. It takes about 2 weeks to look decent. You can typically have bruising. And I'm going to show you a picture in just a second. We like to avoid blood thinners like aspirin, Plavix, Eliquis. If you're a cardiac patient or if you have atrial fibrillation, we like to get you to stop it if your cardiologist agrees. After the surgery, you don't want to change your glasses because occasionally you'll need new glasses with less weight on the eye. It'll change the shape of the cornea and the way light gets in, and you may need to change your glasses. We like you to wait 6 to 8 weeks for stability. Again, to fully heal, it's about 3 months. The key to a blepharoplasty is the lid crease symmetry between the two eyes. And that's what the oculoplastic specialist or the plastic surgeon or ENT doc looks to create. So here's a diagram of what a blepharoplasty looks like. There's an upper blepharoplasty here. This is an outline of the skin that's removed and the underlying fat that can be taken. But as I mentioned, primarily it's skin. A lower lid blepharoplasty can also be done as 3 fat pads. There's something called the inferior oblique muscle, which you have to be mindful of centrally. This is a different procedure. I usually do a transconjunctival approach, which is inside the lid. You don't see an outside incision. And this is typically what you can expect a day or 2 or 3, possibly after surgery. You can see the incision here. These are the sutures. You can tell that the skin has been removed and it's flatter. The symmetry is nice. This is what we aim for. So that's what we shoot for when we do a blepharoplasty. You know, there are other things to take into consideration: the brow, the lash line, which you have to look at if there's ptosis. Ptosis is a different procedure. It's a different diagnosis. That's where the eyelid margin or where the lashes stem from can be low. And that's a whole separate video that we can discuss and talk about. John, as a general surgeon, as a general ophthalmologist, as a cornea specialist, what's your take on blepharoplasties?
Well, I learned a couple of things listening to you that was very informative. I like what you talked about with the eyelid. When the eyelid's droopy enough and it's pushing on the cornea, it actually can affect the vision. I agree with you. And when you lift it, the vision does improve, not only peripherally, but you might get a change in central vision. But I think for my patients, I see 2 subsets. One of the people that just cosmetically, they don't like that extra skin on top, the bags below, and they come to me and I send them to my oculoplastic specialist that I have in my office in New Jersey. I can't send them all the way to Anchorage. And they assess how much they're really bothered. And for many of these people, it's a relatively simple procedure, like you mentioned. They're just removing that excess skin. And then sometimes fat, of course, when it's the lower lids. And with good success. I think you have to weigh the risks and benefits like any procedure. And then there's the functional impairment, like you mentioned, where insurance is going to cover it, where it's impinging on the peripheral vision enough that the person actually feels like they have to lift up their lids to see peripherally. I tell people, like, if you look out at sunset and you can't see the sun coming down without lifting your lid, you probably need surgery. So I think, Carl has a lot more experience in this, I think, in terms of weighing risks and benefits. But my experience has been that the patients are very happy with the results. The risk factors are low, but not zero. And I think you have to be realistic. I mean, I think the biggest issue we see is that it's not completely symmetric in the two lids. So even with a great surgeon with 20 years of experience, sometimes there's a little bit of asymmetry after the procedure. You just have to understand, the enemy of good is perfection.
That's right. So you're absolutely right. So the adverse events or the complications that can occur, you can get an infection. We usually I use gel after surgery for about a week, a couple times a day. I may give an antibiotic pill to take, usually Keflex, covers a broad spectrum, covers staph and strep. And sometimes if you sleep on your face or your eyelid, you can break a stitch and we have to re-suture the wound. Those are primarily the adverse events that can happen. It's uncommon, but you have to be prepared for that. And the two sides of the face are not symmetric. So what we're doing is we're really sculpting and contouring. And not only is it a science, but it's an art. And that's why experience allows you to get better at it, allows you to judge what needs to be done, what not needs to be done, and perhaps to leave excess skin so you don't have trouble closing your eyes.
Yeah.
That's really an issue. I mean, it's always better to have more skin than less skin. If you have too little skin and you have difficulty closing, you can get dry eye, and sometimes you have to skin graft to replace the volume that's lost. So we really, really try to avoid that. And that's why I err on the side of caution. I'm more conservative. And you just have to be upfront and talk to the patient about that during the consent process. But that was it, folks. Thank you for being here. Like and subscribe. This was a blepharoplasty topic. The next video will be on another issue that relates to your ocular health and your vision. And we'll see you then. So long.
Take care. Bye-bye.